faints, sweats, and palpitations. Letter of Referral. Dear Dr. Re. Miss Ann Davies, aged 46 years. Thank you for seeing this woman who has had recurrent episodes of lightheadedness associated with sweating and palpitations. They are occurring with increasing frequency and are affecting her ability to perform her job as a company director. She has a toddler at home and is finding the life-work balance a challenge. She has no significant past medical history and the only family history of note is that her mother suffers from type 2 diabetes mellitus. I am grateful for your assessment as to the likely cause of these episodes. Yours sincerely. Introduction. This presentation could be simply due to stress, but it would be most unwise not to explore the history carefully in routine clinical practice or in PACEs. A fundamental issue here is to determine whether there is a true organic basis for the presentation. In most cases such as this, the diagnosis can be made after taking a thorough history, and clinical examination often adds little. Although the symptoms described may have no clear physical basis and simply represent a response to difficult social circumstances, a diagnosis of a non-organic disorder is a diagnosis of exclusion. In addition, lightheadedness means different things to different people. Individuals with this symptom find their way into various clinics, neurology, cardiology, endocrinology, etc., and a wide range of diagnoses need to be considered. The combination of lightheadedness with sweating and palpitations is more specific in that it suggests enhanced autonomic sympathetic activity. History of the presenting problem. It is important to ask the woman to explain as precisely as possible the nature of the episodes of lightheadedness, sweating and palpitations, and, in routine practice, but not possible in PACEs, to obtain a report from a witness if available, since by the very nature of the problem the patient may not be able to give a lucid account. Ask both the patient and any witness about the following. When and how often do the episodes occur? What is she typically doing at the time? Are there any obvious precipitants? Are the onset and recovery sudden or gradual? What happens during an attack and how long does it last? Can she tap out how her heart beats at the time? Are some episodes worse than others? Whilst answers to these questions may give a firm clue to one of the diagnoses listed in Table 3, it is also possible that the account given may broaden the differential diagnosis still further, and the full range of causes of presyncope, syncope, or vertigo may need to be considered. Other relevant history. In addition to sweating and palpitations, inquire about the presence of any other autonomic symptoms, e.g. dry mouth, tremor, altered bowel habit. Anxiety and depression. Does the patient experience pins and needles in the hands and feet, suggesting possible hyperventilation? Ask in detail about social circumstances, both at home and work, which seem likely to be relevant in this case from the information initially available. Does the woman have a long history of presenting with medically unexplained symptoms? Alcohol and drugs. How much alcohol does the patient drink? Does she take any drugs, prescribed or non-prescribed? These questions must be approached with tact and care. Is she addicted to coffee? Cardiac arrhythmias. Both tachyarrhythmias and bradyarrhythmias can be associated with lightheadedness as a consequence of impaired cardiac output, and may be noted by the patient as palpitations. Ask about shortness of breath, chest pain, and any previous cardiac history. Endocrine and metabolic disorders. Autonomic symptoms can be the presenting feature of both common, e.g. thyrotoxicosis, and uncommon, e.g. pheochromocytoma, Endocrine and metabolic conditions. Ask carefully about symptoms that would suggest thyrotoxicosis, e.g. weight loss, tremor, dislike of hot weather. Neuroglycopenia is a possible cause of lightheadedness, and hypoglycemia must be considered in this woman. If there is weight gain, consider insulinoma. Social circumstances. Whilst most of the history is directed at determining the accurate diagnosis, attention should also be paid to the impact that these symptoms are having on the patient's life, regardless of underlying etiology, e.g. the ability to perform her job and to look after her child. Plan for investigation and management. In a case such as this, your initial assessment is very important in gauging whether the symptoms have a psychological rather than physical origin, but beware of jumping to prejudiced conclusions. Always perform a full physical examination and relevant investigations unless the history is clear-cut. Lightheadedness, sweating and palpitations. In anyone with episodic symptoms, it is invaluable if the patient can be assessed during an attack. Priorities, after ensuring airway, breathing and circulation, are to observe the general appearance, check the pulse, measure BP, obtain an ECG rhythm strip, and test for hypoglycemia with a finger prick blood glucose monitor. Carry out the following routine investigations. FBC, macrocytosis of chronic liver disease. Electrolytes and renal function, low sodium and high potassium in Addison's disease. Liver function, hepatic failure, metastases. Fasting glucose. Thyroid function tests. CXR, cardiac disease, metastases, and ECG, arrhythmia. Further tests should be dictated by clinical suspicion. Cardiac disease, consider echocardiography and 24-hour tape. Thyrotoxicosis. Pheochromocytoma. Addison's disease. Hypoglycemia. Hypoglycemia. If hypoglycemia is shown to be the cause of symptoms, then in most instances the etiology can be readily identified without recourse to further studies, e.g. diabetes-related, liver disease. Occasionally, however, additional investigations are indicated. Insulinoma. A supervised 72-hour fast with regular measurement of glucose and insulin profiles, every 6 hours, and at any time when the patient is symptomatic, will unmask hypoglycemia in most cases. Biochemical confirmation of hypoglycemia, laboratory blood glucose less than 2.2 mol/L, should be accompanied by demonstration of inappropriate hyperinsulinemia and elevated C-peptide levels. If hypoglycemia is found on a finger prick blood glucose sample, immediately take a blood sample for laboratory estimation of glucose and a serum sample for storage for analysis of insulin, C-peptide and toxicological studies as appropriate. The tumor may be visible on ultrasound, especially endoscopic ultrasound, CT, MRI, or angiography, but up to 1/3 of tumors are sufficiently small to evade detection. Accordingly, some centers advocate localization at surgery by palpation under direct vision. Intraoperative ultrasound aids detection of tumors that are too small to feel. Factitious hypoglycemia. Exogenous insulin administration causes hypoglycemia with hyperinsulinemia, but C-peptide levels are low because endogenous insulin secretion is suppressed. In contrast, the surreptitious use of sulfonylureas, which enhance endogenous insulin secretion, gives rise to a biochemical profile similar to that seen with insulinoma. Diagnosis is made by assay of plasma or urinary sulfonylurea levels. Factitious hypoglycemia should be considered in those allied to the medical profession or, as perhaps in this case, where there is ease of access to insulin/oral hypoglycemic agents, especially sulfonylureas. Management. Insulinoma. Surgical excision is the treatment of choice. Regular snacking will minimize the number of hypoglycemic episodes prior to surgery. Diazoxide or somatostatin analogs, which inhibit insulin secretion, may be useful adjuncts in more refractory cases or in those considered unfit for operation. Reactive hypoglycemia. Post-gastrectomy patients should be advised to eat little and often, avoiding rapidly absorbed carbohydrate. Idiopathic, i.e. unexplained, but no sinister cause found, hypoglycemia may respond to dietary manipulation with avoidance of refined carbohydrate and reassurance that there is no serious underlying disorder. Factitious hypoglycemia. Treatment is difficult. Confrontation often leads to denial despite convincing evidence. An underlying psychiatric condition is frequently present and appropriate referral is advisable, although often declined by the patient. Further discussion. Multiple endocrine neoplasia type 1. Most cases of insulinoma are due to solitary benign tumors arising within the pancreas, but a small number have malignant potential and a few are seen in the context of the multiple endocrine neoplasia type 1 syndrome. The latter should always be borne in mind, and genetic counseling/screening considered if there is a personal or close family history of hyperparathyroidism. Ask about neck surgery, renal stones, pituitary adenomas, or other neuroendocrine tumors, e.g. gastrinoma.